Welcome to the J3U University podcast. I'm your host, John Jewett.
And I'm your co-host, Luke Miller.
Our mission is to elevate the physique coaching standard
and deliver the highest level of competitors to the stage.
Let's jump into today's episode. All right. Today we have a special guest with us. It's Michael Warner. He's with Marek Health, and Michael has been a bodybuilder for a while now, kind of breaking in the national level scene. But why we want Michael on is because he has a great expertise as a wellness and health management coach for Marek Health. So he seems numerous sets of lab work in all types of testing and all types of issues and health problems that he is managing. And for Michael, we could say like lots of different individuals from across the spectrum, but one that is near and dear to our hearts is physique competitors and especially bodybuilders, which if you're not familiar, I've mentioned Michael before. He's managing my health through Marek, and also Samson Diodo, so who's become a big name. So you have this insight into open bodybuilding, managing health, and that's why I thought it'd be awesome to have you on today and dive into just lab marker testing, things that we might be missing to really expand more and make a proper assessment when we're seeing some abnormal aspects happen in our labs. But that's what we'll dive into today. Michael, how are you, my man?
Awesome. I'm great, John. Thank you and Luke for having me. It's awesome to be here. Obviously, it's just a fan, both of you guys and the sport, and just to be here and come provide more value and help people out, honestly. So
yeah, I think that's perfect. Like why we aligned well with Marek and J3U is like we're all just trying to elevate the industry and do things at just a higher level. And part of like people, it's so underrated, like managing health, because when you're healthier, you can keep progressing at a faster rate as well. So people are like, oh no, if I'm having to do this health stuff, it's going to take away from me doing the things that I want to really grow. And that's not the case at all. So where are you currently at? You're in your just off-season phase, right? Yourself?
I am, yeah. Currently, it's kind of in a off-season phase, floating around it's like the heaviest I've been around like 230. And I'll probably aim to do a show sometime next year. I haven't really planned it out yet. Just want to make sure that I'm ready. Obviously, like health-wise, but then physically, just being the most competitive, jumping up to another class from middleweight to light heavyweight. So, got to make sure that I take the time to do so. Just can't rush it, right?
Your look's tremendous right now. Like we've talked before, like this looks like it's probably your most productive off season that you've had too, right?
Like, it has been. Thank you.
Full and round. It's awesome to see it. When I see this pics, I'm like, it makes me excited.
Yeah. Oh, no, thank you. I appreciate it. It's, credit to honestly, both of you guys and the education that you guys put out there, because, I've learned a lot from you both, and it just goes to show when you know more and you can approach this, being healthier and just leaner, like you said, it's, you're going to make the most progress. So, it's ultimately why I decided to take this year off, and I have somewhat of a tentative plan for next year, but I decide based on, how the progress is going. So, but yeah, it's been fun. It's great.
Too humble, man. You've put the work in yourself. If we play this tiny little role, awesome. But that's you. So congrats on your progress. But
thank you.
Diving into leveling up, right? We should get into just managing this open bodybuilders' health. Of course, I'm excited because I want to know all the different lab variations that you might see, and for our listeners, a lot of bodybuilders where there are lab discrepancies that pop up, right? And I get the questions of like, is this okay? Like they're trying to feel it out. And usually it's a lot of times lab works, there's testing missing towards might not be fully insightful to be say like, hey, yeah, this is actually liver stress and you should pull back, or no, this is not, and it's able to keep going. So I wanted, just from the bodybuilding perspective of the labs that you're coming across, some of the main standouts of discrepancies, and then even what additional testing might need to be done when you are seeing those discrepancies. So if you want to start, Michael,
Yeah.
like what is kind of the first, or maybe even like the most questioned lab marker that you get because of it being more altered in a lot of these individuals?
Yeah. Gosh, I'd say probably one of the more popular ones, if, when people say, hey, is this okay? Um, Especially in bodybuilding circles, is, hey, is my estradiol or is my estrogen too high relative to my testosterone? And I think that's probably the most popular one. We can get into that. And outside of that, it's, hey, should I donate? Because it looks like my hematocrit or hemoglobin is too high. What's going on there? And then maybe outside of that one, the third, if it's like a top three, um, liver enzymes. Like, hey, what's going on with my liver enzymes? My AST and ALT are high. Is this? I heard it's like due to training. Is it high because of that? Um, and then obviously there's multiple others, but I think if I were to give like a top three, then that's probably the most common questions that I get. It's like, we'll see these having such a huge spectrum of people that I see in labs, and obviously it's kind of quite the gamut in terms of the protocols that people are using that I come across. And it really ranges from your professional bodybuilders to amateur bodybuilders, or people who aren't even bodybuilding at all and are maybe just experimenting for aesthetic reasons or whatever. Um, you see quite a lot, and I think the most popular one really is like, hey, is my estrogen too high? And of course, when you see the LabCorp ranges, they have their own values, and if something is flagged high on there, it's like, oh, what's going on? Is this okay? Is this bad? But you know, you'll see a high testosterone value just based on their ranges, where the values are bold, right? And they're like, oh, I think my testosterone's good, but oh, now my estrogen's too high. Is that okay? So
I think people get really like kind of pigeonholed down, only looking at the one marker, especially like estrogen. So it's just like they see
mhm,
estradiol, and everything else is kind of like blinders to it. And it's just like
right.
estrogen's out of range. Like, I need to do something about this. When you have someone that's coming to you with those labs, do they typically also presenting with some type of symptomology around this, or is it just purely could be mixed? Maybe they are having something, and they just have the marker that's elevated without the symptoms. So what are your like first steps here? If they're like, hey, Michael, here's my labs, my estradiol is high, where do we go from here? Like, and I guess maybe we should even say like what is high regarding like the Marek Health ranges, like for maybe listeners that are out there.
Right,
And
exactly.
it's
So
all over the place with what lab you're going to. I know that, but you know, t- typically I see like,
yeah.
for a lot of guys, it could sometimes the cutoff is like 60 picogram per mil,
Mhm.
depending on these ranges, right? Like a max level for an estradiol level. So, but anyway, what are
Right.
your like first starting points for that conversation?
Yeah, exactly. So the first thing is, I let them know, hey, there's going to be like a ratio. And at first, having them understand that testosterone aromatizes into estradiol, and m- more often than not, sometimes you'll see guys that just don't understand that concept at all. That they're not really related in that fashion. How there's not a ratio. How when testosterone rises, estradiol will rise naturally due to aromatization, and they also kind of they assume that because testosterone high, estrogen should be lower, or estradiol should be lower. So first, I established that, hey, there's a ratio here, and there's a relationship between that aromatization depending on couple different factors will determine what that aromatization looks like. Sometimes that rate can be higher or lower, depending on, if you have a higher amount of body fat overall, you're going to have more of the aromatase enzyme because body composition is just not favorable. Also, relative to the ejection frequency too. So a big one, before I even ask them if they have any symptoms or anything, I just ask, hey, like how often do you inject? And how close to the lab panel did you inject, right? So if I have guys who inject the night before their lab draw in the morning, I've seen labs drawn like an hour after an injection in the morning as well too. So it's letting them know and understand, kind of painting this picture like, hey, like sometimes I'll see guys come in and they'll inject an hour before the labs and their testosterone values are like over 5,000. And they're like, oh, dang, that's crazy. And just to paint this picture and illustrate like how vastly and like how volatile those hormonal changes and cascades can be. And, immediately after an injection. And so I think people get too granular with it and they go, okay, like I guess it's maybe not too high, or where should they fall? So it's just letting them know that the injection frequency matters. Obviously the dose plays into that as well too. How much body fat that they have, and that there's a ratio, roughly 19-ish to 1, or 20 to 1, somewhere around there. Typically it is kind of around that 60 mark for estradiol, but a lot of times I just want to ask them first, hey, do you have any symptoms? Like, are you having any type of nipple sensitivity, right? Most of the time I try to point out the symptoms that they would be able to recognize or understand, right? So if somebody is maybe not as lean, are they really going to recognize as much water retention? They might recognize some nipple sensitivity first. They might recognize some erectile dysfunction, or they might recognize some shifts in libido. So helping them understand that, hey, it's not a bad thing necessarily if your estradiol is high relative to your total testosterone, and just kind of working through that first. And if they do have symptoms, then it comes to overall management.
I think we have this on the J3U forums too. Like people will post up, they're not even their labs, right? It's like a marker, estrogen. Like, what should I do about this? And you're like, whoa, a million questions to follow. Like, quick question, Michael. What do I do about this? Right. It's like, yeah, here's the big assessment piece of like around just understanding like shot frequency, when these labs are getting pulled. Another piece to it too is like, are you using an ultra sensitive estradiol test or just a standard estradiol test? Because just the normal estradiol test, I've seen it could have like a 20% error just in that. So and when you talk about a male range being so low already, that can be skewed by quite a bit to be a 10-point difference between if someone's feeling great or not. And so are we even adjusting a marker on our labs that's even accurate to begin with?
Exactly. A lot of times I'll notice. Oh, okay.
No, go ahead.
Yeah, a lot of times we'll notice too, like because I see like so many of these lab values, we'll catch things, or I'll catch things like when it comes to the estradiol, if their testosterone is like, I don't know, 1,600 nanograms per deciliter, and then their estradiol is like a 25, and I'm like, hey, are you taking an AI or an aromatase inhibitor? And they're like, oh yeah, that's right. Yeah, I'm taking, an astrazole or Adex, and then it's having them understand, okay, like this is going to impact your ratio here too. When did you take it? How much are you taking? I think overall, historically, estradiol is demonized. I don't even think that's old news anymore, or like, new news anymore. It's old news. People know that it's been demonized, and fortunately, I think a lot of people are kind of catching on, going, okay, like I don't need to have my estradiol as low as possible. Does that mean that I need to allow it to go as high as possible? Maybe not, but because it's higher, if you're not experiencing any negative symptoms, then maybe it's just okay and you ride it out. So that's a big one for sure.
Yeah, we say like it's about finding your estradiol sweet spot, which is
Mm-hmm.
its range to work within, but it's also a bit of a moving target too, based around what your total androgen load might be as well. So it's this, like you brought up, that ratio of your androgens to estrogens. So you have really high androgens, it might feel like you have low estrogen if you haven't brought that estradiol up in turn. But then
Mm-hmm.
also, like you said, too high can be problematic. But with the somewhat inaccuracy of some of these labs and all the variability, a lot of this does come down to just like subjectively, how do you feel? And you're like, I
Mm-hmm.
feel amazing. It's like, well, great. Should we modify feeling amazing? Maybe not. But I think that is someone that you do have to get a bit more introspective and self-aware.
Mm-hmm.
And this party bodybuilders really are, but I know if they're earlier on in competing or just lifestyle, that's something they might not be that aware about. And there's also more variables that they're not controlling in their lifestyle. So I know for me, like if my estradiol gets too high, the first things I'll kind of notice is like sleep quality is it goes down. I have
Mm-hmm.
a harder time getting deep quality sleep. Um, and you know there's a that aspect around it for me at least. So I think historically in bodybuilding, we're like estrogen makes you hold water, you lower estrogen really really low, so you can look dry and hard. But I feel like we are moving past that. I just had my labs pulled, right, Michael, and my estradiol was a 70 or 78 picogram per mil, which is a little higher, but my androgens are pretty high right now, so I look like dry and hard.
Mm-hmm.
Even on the female side, like
Right.
estrogen goes so low in these females that they're losing their menstrual cycle, and then there people are like using AIs and serums as a misapplied compound when estrogen is already really really low. So we actually even have females like when we won't mention who it is. I guess I was about to say it, but she's actually brought in replacement estradiol in her prep, and she's like, I feel so much better now that I have that in place. Like energy's better, sleep quality's better. So I think it is a big shift that estrogen just shouldn't go as low as possible. That within
Right.
female or male physiology, it's like, hey, a sweet spot, and it's also going to shift around depending on what phase that you're in.
Yep.
Uh,
Unfortunately, I see that a lot where the same application that people historically take to males and going, hey, I'm going to throw this AI here, got to have estradiol down because it's going to make you hard, right? That's the sort of the logic. They apply that completely. They just kind of drop that logic onto the females. And obviously, we see that down regulation in the HPG axis. And, you have that estradiol down and progesterone down. And then you have to also consider, are they on birth control too? Is it already just naturally suppressed? And so you bring on this allostatic load of stress in general just from being in a calorie deficit. How long has that deficit been? Is it a little bit more chronic because are you doing show after show? Are you trying to stay lean? Do you have any type of uh, the psychological type of eating disorder, and then you have relative energy deficiency and everything is just smashed down. And then they throw an AI on top of it because I think that's what you're supposed to do. That's tough. It's a tough one. I see that a lot actually. So,
Getting back to like skewing of the actual lab marker itself, because with bodybuilders you're having guys that just they're not just running testosterone, so there's other things in place too. um, have you seen like alterations in just like we mentioned cross reactivity with other compounds that skew the lab? Is this something you come across much, or what would someone need to be aware of regarding that?
yeah, absolutely. So, we can see this kind of cross reactivity with progesterone, especially. And then um, you can even, which will then lead you further down to, okay, like what does pregnenolone look like? Are you taking pregnenolone? Is that affecting progesterone? Is that then therefore affecting in some way your prolactin values as well too? So you have to understand that what I try to do is people, it's like you got to get really granular and then you got to zoom back out like right away. Um, and you have to kind of go back and forth between that because they get so like, hey, my prolactin's high. Oh my God, this is an issue. What do I do? And it's like, well, what's driving that prolactin to be high? Is this, is estradiol going to be this kind of main driver of prolactin? But then are you also having some cross-reactivity from some other compounds that you're using? So again, it's so easy. I think we're so like, a lot of us are kind of driven. You see these numbers and you go, okay, here's this problem. I got to focus on this one. What's going on? And it's like, okay, yeah, I get that, but hold on, let's back up. Understand that we might be having some sort of crossover here, and we have to address this as a whole and understand it's like a symphony. Like one thing's impacted or influenced, it's going to impact and influence something else here. So quite often I see that with polypharmacy.
Yeah, especially like we pulled my labs and my estradiol is higher. However, there was like trenbolone in place, which now we don't have studies in humans around cross-reactivity of trenbolone and its impact on these other hormone markers, but just through coaching experience, I've seen that estradiol is increased with trenbolone usage because it could be very well cross-reacting, but it's a bit more of a case in point that you should be getting an ultra-sensitive estradiol test because that would minimize the impact of that cross-reactivity of a compound. Same thing could be potentially if you were, we don't normally pull like a serum DHT level, but if you're taking a DHT derivative that structurally looks a lot like DHT, right, if the lab is not that accurate and sensitive to detecting that, you could see really high DHT. However, it was a DHT derivative, but also these other compounds that mirror one another. Same with like testosterone and maybe boldenone, both a testosterone derivative. Like if you're not getting a sensitive test, it very well could show like you have really high testosterone levels, or maybe you actually don't have the compound that you think that you have. So I see that in labs come back a lot too. Like people think they're taking testosterone and they have their primobolan present, and their like testosterone estradiol are like way sky high, like to where it doesn't even make sense on the amount of testosterone that they're taking. It might very well be that their primobolan is not actually primobolan and that it could be something else. So, but again, like you said, it's not clear cut in labs. And I think as just humans in general, we like it real black and white. Like estradiol is high, we lower estradiol. It's like, that's not the full story. Like, right. I think of this as like looking at labs, like trying to investigate a murder scene, which Renee and I are watching all this true crime stuff. So,
so do we.
So you'll have like one witness, right, in this lab marker, but we have to like corroborate the story and build a case. So we're looking at other markers, we're getting like subjective feedback, and then finally we kind of have a story around why this crime might have happened. But we know with like when you take these like to jury, sometimes it's not so clear cut. Like, oh yeah, this guy absolutely did it. It's more like the evidence kind of supports this, and we think it's a really good case for it. So same with like estradiol or other lab markers. Like, hey, here's like all of our evidence from our other lab markers, the subjective feedback. It's likely probably this is the root issue, and we should start there to address it. So it's not so clean cut. It's a lot of critical thinking that's present, and why we should have someone like Michael present or with Marek Health to where we can help not have to like just rack our brains around this, because it is pretty complex to manage.
Yeah. I think it's kind of corroborating the story here, or like helping people understand how things correlate is a big one. And I think with bodybuilders in general, it's like you have these main players that you're typically going to have in, whether, from androgens or growth hormone in particular. And speaking of, estradiol, one of the things I kind of like to point out to them is, hey, look, do you have this growth hormone in? Usually we can tell, hopefully we can tell, by looking at their IGF-1. And a lot of the times, I'll just say, hey, like, you must be, when I see that testosterone to estradiol ratio, and if that estradiol is low, Then I point them to their IGF-1, and maybe they have another previous panel in there, so we can kind of look at two different ones. And I say, hey, look at your testosterone to estradiol ratio to your IGF-1 ratio, and look at and see how they're all correlated here. You were thinking in your head that you need to reduce your estradiol and crush it to be like drier. And then at the same time, you're also taking this growth hormone, however many units, but you can just see the relationship between your estradiol and your growth hormone, and then or IGF-1 shown as a proxy here. Look at how IGF-1 lowers, the lower your estradiol is. And when they kind of understand that relationship, when estradiol is higher, you're going to see this more growth hormone to IGF-1 conversion. Does that mean you need to chase the absolute highest amount of estradiol? No, not necessarily. But if you kind of zoom out and you start to see how they correlate, it goes, okay, well, I'm taking this growth hormone. Am I wasting my money by taking these AIs or taking this SERM because I feel like I have nipple sensitivity and I'm not going to stop the amount of testosterone that I'm on. I only inject once a week or twice a week. And it's like, hold on, you got to lay all this out. And so this is ideally when I try to lay all this out and say, hey, like all of these things are correlated, and there is like a golden sort of like space here where things have to be to get the most out of everything that you're using. Yeah.
I think there's also potentially like a phasic thought process here as well, and like relationship of different phases, seeing like some skewing happening that would technically be acceptable versus not acceptable, and then where it could point you in like different lab works, and not only phasic but like risk profiles in athletes, because there's levels of skewing within really high risk profile athletes during certain phases that's temporary, that's a part of the process to the goal that might not be acceptable with these earlier level athletes. So like this is an interesting dynamic to manage from like the health metric side of the equation. And it's like something I'd like to hear you comment on is, how are you managing that? Because when we're looking at this symphony of like your prolactin example, like prolactin elevation, oftentimes permissive from an estradiol perspective, we're seeing this in this relationship of labs. Like, how are we managing this relative to risk profiles? Because when we start looking at like kidney function, liver function, all of these lab markers that are going to start to cross within other areas of long-term health, like there is that athlete side of the equation that we have to take into consideration of what is the long-term goal. And we also see this happen a lot on the female side of like what's acceptable for someone with high levels of desire for fertility is not acceptable for the WPD athlete who doesn't care about having kids in 10 years, right? So that dynamic can be tough to manage, but I think it's something that you do well just based on like some of the interactions we have. And I think it's a talking point when you are looking at this labs to kind of touch on quickly.
Thanks everyone for tuning in to today's podcast. Are you struggling to hit your peak on show day? Feeling lost in the off season? Upgrade your coaching game with J3 University. Our program covers everything from off season to contest prep to peak week, all based from real client results. Along with our comprehensive physique curriculum, you'll also get access to our 4 rooms with our J3U team to answer any questions you have, and live Q&A sessions to further your coaching and athlete experience. We are the source of education for top IFBB pros and coaches. Join us to elevate the coaching standard at J3 University. Let's get back to today's podcast.
Yeah, great point there. I think when we think of long-term health, longevity, some of the simple things that they can do, actionable items that people can do and take away from and to manage their overall health is, hey, are you taking these anabolics? Are you a competitor to any degree? What level competitor are you? Are you an open bodybuilder? Are you overall heavier? Do you check your blood pressure? And that's a huge one. Ultimately, unfortunately, I don't see a lot of people taking their blood pressure. And really, when I try to just lay this out from a health perspective, we look at their labs and, we can see some elevations here in their hemoglobin, their hematocrit, their red blood cell count. Ultimately, how that is going to affect and influence this blood pressure, their kidney function overall. So obviously, there are some areas that we accept the risk, right? An informed risk, it's, hey, are you okay with this? What are your symptoms like? There's some sort of hard cutoffs, and ideally if you don't know where those cutoffs are, where it's like, hey, we got to stop this here. Ideally, you have a coach that's like, hey, based on your symptoms, based on how you're feeling, based on this lab work, this is a hard line that we're just not going to cross, or I'm not comfortable crossing. So knowing where those are at. And oftentimes when clients who maybe don't have a coach, or they get their lab work, they don't really know what they're looking at. It's like hieroglyphics looking at it, but it's pretty easy to understand blood pressure values. So it's one of the main ones. I just say, hey, please just take your blood pressure. If you're taking enhancements to any degree, do yourself a favor and take your blood pressure. And so that's a big one, right? Obviously, we're going to see some fluctuations in blood pressure when somebody's like in an off season, they're reaching some peak weight. They're maybe at their peak PED dose overall. And so, okay, maybe there's some room, like some gray area where it can go up a little bit, but as long as it's like an acute sort of phase and it's not chronic, right? If somebody's, hypertension, level 1, and then that gets into all of a sudden their systolic is over 140 consistently. What are we doing to help manage that? And again, how does that impact and influence their overall kidney health? And then you remove the bodybuilding picture altogether. How is this going to influence long-term health overall? Are you consistently taking these orals because you like the way they make you feel, or they make you harder? What is this doing to your liver enzymes? Are we creating any sort of fibrotic development on your liver that's obviously ultimately going to affect your long-term health overall, and the capacity for you to just excel as a physique athlete too? And so, yeah, there's some risk there. How much of that risk is acceptable obviously is up to that individual alone, but this is where you have somebody as a coach and a guide to say, hey, like, this is not okay. And we can only go so far,
It's such a hard, you're not going to get a hard answer from this, because it's a very gray area and a one that's unknown of like that amount of risk that you take. We don't know what that's going to add up for you as a unique individual. So I think we would review all the risk factors being present, right? Like, is it high blood pressure? Are there like risks in their compounds that they're choosing that are more problematic for their own individual health profile? Like, maybe we can make modifications that improve that, or even add in some strategies like blood pressure medications or statins, things that can improve health under the same type of risk that they're taking, and make that risk reduction. So I think there's just, pharmaceutical, supplemental change, and lifestyle changes you can implement. They're like, okay, we can improve this, and now we're in a sustainable spot for your bodybuilding. However, there absolutely are going to be acute phases, right, during the year where you might see some level of skewing. I think where this becomes problematic is like, hey, the majority of the year I live with this hypertensive state, or the majority of the year my LDL is skyrocketed, or kidney function is down. It's like, that is likely where, if you're going to bodybuild now for 10 years, you're going to live 10 years of your life under this. That doesn't usually look great for morbidity and mortality outcomes. Then I would next consider, like, within this phase that you're in, is this going to impede our impact for this year, this show? What about the next duration of your bodybuilding career? What about after bodybuilding? So it's like weighing all these things out, but we won't have clear-cut answers. But I think we're really at a place where, at least a lot of the guys that I coach, even I have big guys. I have guys that are like over 300 pounds, where you can do a great job controlling health markers and see pretty low skewing, to where, it's not great being a huge bodybuilder on PDs, but at least like we have the awareness to make changes to the program based on assessment, which goes back to your point of, you probably should be pulling these labs every 10 to 12 weeks and seeing what this current protocol you're doing is affecting you, and make those adjustments that you have present to where, as an individual, if you need these certain type of medications, or you can adjust your PD design to be a little less health risky. And I'm sure those are the kind of the conversations that you have, and it's hard to give a direct answer of like, hey, this is we don't take it to this place, right? It's very unique and individual, but just more of a case why you need a good team around you to help evaluate and make those decisions.
Yeah, absolutely. I think just specifically, when we think about blood pressure or, just these compound polypharmacy, a lot of times I'll get this, like, there's a disconnect, like, hey, I'm willing to take any and all of these performance enhancing drugs, but I'm not willing to take any sort of like medication to help with my blood pressure or to help with my lipid profile. It's like, hey, look, like, maybe that doesn't really line up, so much. Like, why, does this make sense? Why are you're putting yourself at more risk? We should probably have some other, prophylactic strategies in place. When it comes to like kidney and blood pressure, I was talking to you about this, John, yesterday. I see a lot of guys, even if they're not in a push phase and PEDs are at their highest, but they're still relatively heavy. Oftentimes, I'll see that red blood cell count, hematocrit, hemoglobin higher. And I'm like, hey, like, do you snore? Do you have sleep apnea? And a lot of them do. A lot of them do and don't even realize it. And so they're like, they look at their labs. I had one yesterday. It's like, dang, I just donated. And I actually ran out of my testosterone. So I'm not even on it. And my levels are still high. And I'm like, okay, well, do you have sleep apnea? He's like, yeah, it doesn't have a CPAP at all. And it's helping people understand that, like, look, when you're sleeping, you're not getting enough oxygen. You're hypoxic, right? Your body is literally just going through this defense mechanism. Hey, I'm not getting enough oxygen to my tissue. I have to produce more, right? More red blood cells, more hemoglobin to get that oxygen to my tissue. What is that going to do? Ultimately, it's going to make that blood more viscous, right? It's going to increase blood pressure, blood volume. And so you're seeing those elevations there. And the thought process is, oh, I just need to keep donating here to keep lowering this. But then they ignore the sleep apnea, don't get a CPAP. And then on top of that, you factor in, well, if you're adding in other compounds that are going to increase erythropoiesis, if you're going to add something like EQ, something that does that higher than anything else, if you're going to increase whatever else it is, testosterone at these higher levels, that's just going to exacerbate the issue. So sometimes it's removing this, hey, it's not even necessarily just these PEDs or testosterone alone that is increasing this red blood cell count, overall hemoglobin. It's you just are losing oxygen at night and you're heavy. And this can come with guys who are obviously not even just sloppy heavy, right? Where body composition is out of whack. You can be lean and be heavy too and still have sleep apnea. So it's a major one that people ignore too often.
Yeah, I've been dieted down to like 205 and I still have sleep apnea. Like it was like a structural aspect around and muscle and size, made a difference. But I would, so many people I find are like reluctant to go get a sleep study done. And they're so easy now. They're like, you can have one mailed to your house. You need to go to the doctor and have this done and they can send you a CPAP. Like you don't even need to go anywhere to have this. But for me, wow, it's a game changer. And Luke can say the same thing, not just for like recovery from training, which if you recover, you can now train more and get more stimulus and more adaptations. Like you'll grow more. Like, hello, everybody, wake up. Like get your CPAP if you need one. But also like the cognitive function side. Like, man, if you're not sleeping, like the neurological recovery that happens at night, you need it so much to be able to work and focus the next day. So like even from that aspect, like it's a huge elevation to be able to work more and then train more, do everything more. So it's a big thing that gets neglected. And I don't know if like, at least now, man, there's so many advancements in the CPAP machines, mask, and everything, to where they can be pretty comfortable and
Yeah.
not be like that restrictive or
Right.
impact you having to wear something at night. So
I went through it too. I went through that, like, I guess speaking of, and I don't get any like credit or kickback from this, but you guys, if they just go to Lofta, LOFTA.com,
since they look at
go get their, like, yeah, get the at-home sleep test. I know Merrick has a code, like Merrick 5050, like take some discount on there. Literally, they just send you one at home. They'll put it, you got the pulse ox, you got the little watch thing, and you got the lead that goes up. Just sleep with it, send it back in, you'll get the results. They'll send you back this like really cool, like PDF, visually appealing, user friendly to read, and they'll just give you a bunch of data, and it might freak you out enough to be like, oh shit, okay, I got to take this seriously enough. I went through a couple different masks because they're like uncomfortable, honestly. Like I tried to sleep with the full like Darth Vader's mask, couldn't do it. I finally ended up with like the just the nasal one, and it works well. But I think when you finally sleep with it out and get used to it after having sleep apnea, you're like, damn, I feel refreshed today, or I feel I don't have any brain fog. This is crazy. It's just a major one that people just kind of ignore for whatever reason. I don't want to sleep with that. Old people sleep with those. Like my grandfather sleeps with that. I don't need to sleep with that. I hear it all. And it's just wild. Like, hey, you're doing everything you think you are to grow and be better by taking whatever drug, or how much of this should I take, or when should I take this, and should I take it for this amount of time. Like, let's expand that to the health side as well too, to make sure that we're yielding the absolute best amount of progress we can.
a lot of people will come up, be like, I'll do whatever it takes. And it's like, it's easy to do the what it takes part, but it's hard to do like, what do you do? So those are all actually the hard things. So it's not just like, yeah, man, you could take all the stuff, but you need to do actions of hard things like routine, habits. Like those are things that people fall off on, or getting testing done and trying to pull apart that testing and optimize the other aspects of your health. Like those are your big ticket items. Addressing this hematocrit piece too. I just see guys too, just like they don't hydrate enough prior to labs, which your hematocrit level is a percentage of volume per blood. So if you have a low amount of blood volume because you're not hydrated, that amount of hematocrit could be artificially elevated. So I think it's just extremely important just to make sure you do drink. Like, yes, labs are fasted, but that's not exclusive from water. So make sure you just have adequate hydration. I've seen mine swing like 4 to 5% just if I was hydrated or not. So we could do a deep dive, I think, into hematocrit cutoff points and, how do you address these things? What is actual risk? And then get into finally like the mixed opinions around blood dumping. I think that's just beyond what we can cover in this section, but it's worthy of its own conversation, because I think that is one that has a lot of confusion around. But I want to touch on the last marker that you had brought up, because we get so many questions around it too, is the elevation of LFTs, liver enzymes. They're not just liver enzymes, but when you do see these elevations, where's your start point of where you start looking to other things and asking questions around, is this actual liver stress or is it not liver stress?
Yeah. So obviously we'll be looking at, your AST, your ALT. We'll be looking at ALK Phos. We'll also be looking at GGT. And I first kind of understand, like, do you have any previous labs where I can kind of compare these values, right? What is the ratio of AST to ALT? Is AST higher than ALT? Is ALT higher than AST? If so, like, how much is that ratio skewed? Did you train close to when you had these labs drawn? I think we've seen you probably need to take, for some of these bigger guys, like almost a week off to not have any sort of liver enzyme elevations at all. Outside of that, are they taking any sort of oral steroid at all? Is nicotine in place at all too? And then, yeah, what sort of liver do they drink? Drinking is a big one too. Are they like the type to socialize and kind of have a couple of drinks on the weekend? Did they get their labs done after a birthday that they celebrated? So all of this is important. And then how does that also relate to, we can't ignore their lipid profile too. Like, are you noticing some elevations in triglycerides? And is this ultimately a result of like MAFLD or NAFLD? Is it metabolic associated? Is it just like alcohol associated? What is going on with the liver here overall in terms of like diet, in terms of activity, in terms of drug use, recreational drug use? So all of that has to really be considered overall to kind of help give context as to why these values might be higher or lower. And, sometimes I'll see these liver enzymes being elevated in somebody who is pretty straight edge, doesn't drink, doesn't have any nicotine in place, doesn't have any whatever other recreational drugs, doesn't even use PEDs at all. And we'll see those liver enzymes elevated by just like AST and ALT, right? And maybe your AST is higher than your ALT. Well, hey, like AST is going to be more present in the skeletal muscle relative to ALT. That's more present in the liver. And then you don't see gamma glutamyl transferase elevated or GGT. You don't see alkaline phosphatase elevated. So then, okay, cool. So maybe it's really not that bad. If we do see some liver enzymes elevated where ALT is quite higher than your AST, where GGT is also, 70 or above, we start to see something like that. I'm like, hey, maybe we should do like an enhanced liver fibrosis test, an ELF test. Let's see where those values are. Are you kind of greater than a 9 there, or what's going on? And I've seen all those tests, and sometimes they're higher. And then if we see an ELF test come back where it's pretty high, then hey, we should probably go see a specialist. And if you're a bodybuilder and you're taking all these drugs and steroids, maybe it's time to hit the pause button really quick, and we go really check out and see what's going on with this liver, and if there's any sort of fibrotic development that ultimately, could lead to cirrhosis or something. We need to stay far away from that. So painting this picture, context is so important into the lifestyle overall to give us some understanding as to why these markers might be the way that they are.
I think a good understanding point for a lot of these individuals is that we call them liver enzymes, but a lot of them are just not only in the liver. And so, right. Especially with, and so you get a lot of physicians or that are like, you have liver issues when it could just simply be from training related, like musculoskeletal breakdown. And those enzymes are present there as well, which you mentioned, Michael, like ALT is a little bit more specific to the liver. So we're seeing like that one skewed more up higher than AST. It could be the case that it is more liver related. I think a consideration point here is that these enzymes also have different half-lives. AST has like a 20-hour half-life, while ALT has nearly a 48-hour half-life. So say you trained, your AST will spike up and it'll come down relatively pretty quick. However, ALT will keep building up and take a lot longer to come back down. Now, this could be like 7 days after. So if you pulled labs even 3 to 4 days after training, your AST might have come back down. You might only see the elevation in ALT, which based on like, well, ALT is more liver specific, you'd be like, oh, dang, I have actual like liver stress going on. Right. But when you actually look at like, that's why you might need like, hey, you actually need 7, maybe even 10 days off of training to truly get an accurate picture if this is liver stress related or not. You brought up some other points too, though, that like in those studies where they look at athletes and enzyme elevations, usually it's just AST, ALT that are elevated, and the like ALK-Phos, GGT, lactate dehydrogenase, those are not elevated. So that might be a way to help kind of corroborate the story. Like, hey, is this training related or not? I'll even have like a creatine kinase added on too. Because I'm the guy that has constant liver elevations, and you've said to the doctor's like, hey, did you ever have like a liver scan done, right? Like, oh, like what's going on with John? And my creatine kinase will be like, 6-8 times normal, because it's just purely from like training, especially in prep. Like if you're doing cardio, you're posing, and you're under recovering slightly, and you have resistance training, like, man, your muscle breakdown that's occurring could be pretty dang high. So you might just have that skewing, but then you have to paint the rest of the story. Like, what other drugs are you taking in combination? Like, are you using oral steroids? Like, all those things could add up to be, it could be some liver stress. But I think people get a little tied up too, I think, on the liver markers. As the liver is pretty resilient, and it's more of like the acute organ issue, when like long-term organ issues are still more pertinent for the like kidneys, heart, and brain. So I think we get so tied up on like, what about my liver? Like, what about your other organs? But before we get to that, anyway, I think, pulling all those markers to try to evaluate, is this just muscle tissue breakdown, or was this actual liver stress, can help delineate that a bit. And in those like athletic studies, some of those individuals were like 3 times the normal limit for their AST and ALTs. So when I see like numbers that are around that, I'm like, this could be like training related, but you have to look at all the other markers to really evaluate it and make sure, because I have times where it absolutely could be liver stress related.
Yeah, exactly. Understanding the individual, that's where context matters, a lot. Obviously in the bodybuilding space, most of us are going to be kind of training hard. We'll see creatine kinase elevated. We'll see, lipid skewing as well too. That can ultimately kind of affect what's going on with the liver. And there's obviously correlations there back and forth. So is somebody getting into bodybuilding and they're still an amateur, but then they have some insulin resistance, and there's overall, like, metabolically, they're just not incredibly healthy. And that's where we start to kind of branch out between liver, other metabolic markers overall. And it's just important to look at those inflammatory markers too, right? Those are like the large ones, right? What does C-reactive protein look like? What does homocysteine look like? Can we look at your ADMA and SDMA? Ultimately, are we looking at any type of inhibition to nitric oxide production that, again, leads back to our blood pressure as well too, and what's going on with kidney function? So these inflammatory markers are important. And then especially if, again, thinking back to the liver, what's going on with ferritin, right? Ferritin is obviously a storage marker of iron, but that can also, it's an acute phase reactant and can be elevated if there's some inflammation present too. And do we need to address that to any sort of degree? And that's kind of when you kind of go back to, all right, are there some elevations in your CBC? And then are we also noticing elevations in your anemia profile, in your iron profile? What does that look like? Is iron super high? Iron saturation really high? I've seen it all. Some of these bodybuilders don't even know that they have hemochromatosis. Some of them don't even know that they're anemic. And
for people listening, could you explain what that is?
Yeah, of course. So hemochromatosis would be an issue with what is called the HFE gene. So hepcidin is kind of this master regulator of iron storage. And if there is if somebody has, you can test for this, right? You can test for HFE. If somebody has a mutation in that gene, you can see some kind of unregulated, so iron overall in the body. And so this is where you can see iron super high, iron saturation getting incredibly high, which obviously we need iron. But if those are completely elevated, that's going to increase blood volume, blood pressure. And really the solution for hemochromatosis there is blood donations, like frequent. So somebody like that would need to do some frequent blood donations, not necessarily somebody who's just using PEDs, maybe not in the smartest way, and has some elevations in their CBC. So yeah, it's ultimately a mutation in what's called the HFE gene, which impacts hepcidin or hepcidin, however you want to say it. And then obviously somebody who's anemic is somebody who has like really, really low iron overall.
I know you threw a lot out there, Michael, and I think there's some like real values in those tests, because a lot of those lab markers I don't see in a lot of the standard testing out there. And for a bodybuilder that's trying to really optimize their physique, I think a lot of those, for one, that just might be unknown to test for, but maybe even underrated. That we know like the root issue of a lot of these disease states are oxidative stress and inflammation. And especially like for just taking PEDs, it increases inflammation and oxidative stress. So shouldn't we be testing that in our labs? Like, yeah, that would seem like a no-brainer, right? That can give insights to the root issues of these metabolic issues that you might be seeing, and increases risk for blood clotting or insulin resistance or cardiovascular disease, and making your LDL oxidize more. So looking at something like Michael mentioned, like C-reactive protein, if you're not testing for that, or your homocysteine level, if we're seeing elevations there, you might have more oxidative stress. And a very common like gene defect too is someone that doesn't methylate properly, like B12 and folate, and they have elevations on homocysteine. They might need special supplementation for methylated B12 and folate. And this is one of the things that Marek can test for. It's the MTHFR gene, methyl hydrotetrafolate reductase. It's some enzyme that methylates, basically. Very common gene defect that you can test for. Another cool gene one that would be very insightful for a bodybuilder if you are seeing elevations in hematocrit is factor V Linden, which is a gene defect that increases someone's risk of blood clotting. And not to go down the rabbit hole here, but it's not necessarily a higher red blood cell count that would increase someone's risk per se. It's more of this increase of the blood clotting factors. And if you are also taking, PDs, and you're driving inflammation in blood cells, and you're damaging blood cells, damaging blood vessel walls, well, you're having to have more clotting happen to repair these blood vessel walls. So if you now have a gene defect that also increases your clotting risk, that in combination with the higher inflammation PDs, it could set you up for a high risk of throwing like a blood clot, having this deep vein thromboembolism. So if your PDs, like this could be something that's you tested for. And the studies that I was looking through for testosterone replacement therapy and the actual risk of like a deep vein thrombosis, if you correct for secondary clotting risk factors, it actually the risk of TRT versus someone that doesn't take TRT is no different. So it's usually something like a factor V Linden, or maybe they had like major abdominal surgery present. We saw this actually with John Meadows, right? And he had his blood clot, or they have like long duration air flights or something that would also increase risk of clotting. But getting back to the point here of like, hey, the MTHFR gene, factor V Linden, like these are pertinent gene tests that a bodybuilder might do if you're seeing elevations in hematocrit or you're seeing elevations in homocysteine, to address those is these are some like root issues that might lead to some things that could definitely been avoidable to begin with. So you brought up like those markers. Those would be really good add-ons that aren't typically tested for. Other ones that you really stand out, like, hey, a vitamin. You mentioned ferritin. Ferritin usually isn't tested for either, and probably is the most insightful one for donating blood to lower iron levels, maybe even more so than the lower hematocrit. But we see like high ferritin levels is independent risk factor for cardiovascular disease, which in bodybuilding, what do we eat a lot of? Red meat, fortified grains, and we're also taking PDs that increases iron absorption too. It's like, yeah, you're kind of like a factory for ferritin at this point. So checking that marker would be extremely insightful for lowering oxidative stress from higher iron in the body. So like those three add-ons you just mentioned, homocysteine, CRP, and ferritin, are great ones that, would you say you always like to test for those every 10 to 12 weeks for your bodybuilders?
Always, for sure. If you are an enhanced bodybuilder, it's like those are given. You have to. You have to. I wouldn't, any of my clients that I have who are enhanced, I'm always checking an anemia panel overall, because sometimes you'll see that. Like you won't even see like iron saturation on there at all. So anemia panel, and then it also includes our ferritin on there for sure. Homocysteine, absolutely. CRP generally is going to be included on there. But if for some reason it's not, like I'm always including that for sure. And you kind of mentioned the whole like blood dumping thing. Obviously there's a lot of rationale behind that or not, but before seeing just your CBC, obviously if it's incredibly high, then yeah, you can go off of that, but and then what's high, so, but always checking that in relation to your anemia panel is incredibly important. So for the enhanced user, those are markers that we always want to get. Male, female, it really doesn't matter. However, also knowing that if you're a female, those iron values and your iron needs are going to fluctuate and be different than males. So that should be included too.
No, Michael, that's great. I know there's so much more to talk about and add on here, but I know today we mentioned like, hey, we'll focus on a few standout labs that you see coaching, like people that are competing. I want to give you just some moments here though to talk about Marek and yourself, and for competitors, or if they're not even a competitor, what Marek kind of offers, and what would be his like first steps to like reach out to get in with Marek.
Yeah, absolutely. So I am a health coach at Marek Health, and have an awesome opportunity to work with plenty of your clients, and then also some incredible athletes. But we work with anybody. It doesn't matter. You don't have to be an athlete. It could be anybody. What we do at Marek Health is it's proactive, right? Proactive healthcare. We'll overall test. We'll meet with you. We'll understand what are your pain points, what are your goals, what are we looking to achieve. Understand your health history. Ask you a barrage of questions to overall gain context and understanding to your lifestyle. We'll take that, and then we'll assess to see what lab panel might be the most effective for you overall, just to provide the overall best care. Once we have that lab panel, we'll be able to review that lab panel with you, not just with myself, but our medical professionals as well. And once we have all that information and insight, we'll be able to assess what sort of treatment options or plan would be best for you moving forward. And this is not just limited to the bodybuilder or enhanced bodybuilder. This is everybody. So that information is obviously critical, and we've been able to improve many different lives. And what you can do if you're interested in starting with Marek Health, you can obviously go to marekhealth.com. I'll put a link in here where you can meet directly with me. And obviously, John, you guys have your own J3U panel that you can do as well, that you kind of built specifically for your demographic too. So yeah, you could find us that way.
Yeah, thanks, Michael. I'll put that in the show notes and description below if they're watching on YouTube, and just to like speak to the process as well. I've had bad experiences in the past with trying to come to physicians with lab work and just getting judged and being told like, hey, you should just stop doing this. And that's not really the option. It's more like, how can you help me manage this while I do it? And so you just get shunned by a lot of different providers. So it's refreshing to have Marek, that it was non-judgmental, and people like yourself, where we can have a conversation and collaborate on like this aspects around my health, and you understand bodybuilding. That's so key. Even the physician I met with, he understood bodybuilding, right? So, and you realize like it's not just Michael there's a whole team with Marek. So if you had something really off the wall, like you have a number of physicians that can review all of this, and they have team meetings. So you basically are getting set up with like a whole medical team behind you for your bodybuilding or for your lifestyle endeavors. But I'll leave that all below, Michael. So I just want to, thank you for your time to come on and just talk to us about this. I think it's just such an important topic, and it's great because I think in the current era, we're really getting this more open-mindedness to managing health. And there's so much great information out there. We just need to make sure people are getting directed to the right places, because there are some practices out there that are just focused on just selling medications or prescriptions, and when you really want someone that's going to be managing your health. And that doesn't mean just selling you prescriptions. It also means diving into all these questions and addressing lifestyle factors too. And even when I got my protocols in from Marek, it came along with like a different lifestyle areas to address as well, which I thought was awesome, because a lot of times clinics are just like, all right, let me sign you up on these medications. Here you go. It's like, I think we missed a few questions in that, but anyway, thanks again, Michael, for coming on. Thank you all for tuning in and listening to you. If you have any questions, you can leave them down in the comment section for us, and we will talk to you.